Hello, everyone, and thanks for attending this presentation on drug testing and regulatory monitoring. My name is John Furman, and I am the Director of Washington Health Professional Services, or WHPS. And WHPS is the Washington State Regulatory Alternative to Discipline Substance Use Disorder Monitoring Program for nurses. I'll talk a little bit more about what that is in later slides, very briefly. However, I've also been very involved in the regulatory occupational health landscape for a long time. I've been in this position now for about 8 years, and prior to coming into this position, I worked for the Washington State OSHA program, writing statute and rule in regards to the occupational health realm. So that's just a little background on me. So let's start with the presentation. Drug testing and regulatory monitoring. Drug testing is an important tool in the regulatory and legal monitoring of individuals with substance use disorder and/or work and safety sensitive positions, such as healthcare providers and airline pilots. Due to the legal and personal ramifications of a positive drug test, this type of testing, also known as forensic drug testing, is conducted under strict structure and multiple redundancies and checks. Regulatory drug testing now commonly includes the use of panels that include 10 or more drug classes. And this is in contrast to what was done just a little while ago, several years back, when most commonly what was termed the NIDA 5 panel was used for most regulatory and workplace monitoring. And that includes drugs and drugs classes such as amphetamines, cocaine, marijuana, opiates, and psilocybin or psilocybin PCP. So more regularly now in our type of monitoring, forensic monitoring, at least 10 and maybe 15 drugs or drug classes are used. And you may have noticed in that list I just gave, things like alcohol, which is surprising, is not included, and also classes such as benzodiazepines, barbiturates, and other things now that we regularly test for, such as MDMA or ecstasy. And depending on the situation, a program may want to include over-the-counter drugs such as dextromethorphan, or also other substances such as kratom metabolites. So I do want to say before I go any further that I have no conflicts of interest or disclosures. And the objectives of this presentation are to identify the characteristics of forensic drug testing and the differences between forensic and medical drug testing, which we'll go over briefly. Be able to follow the path of testing from collection to reporting, also called the chain of custody, and identify the role of the medical review officer and result determination. An important takeaway from this presentation is the realization that a drug test in and of itself cannot definitively tell whether one has or has not misused a drug or answer the question of impairment. It only establishes a probability of use. The medical review officer, along with other investigatory and evaluation tools, complete the picture and help to develop an action plan going forward. So drug testing, regulatory and workplace drug testing, and or forensic drug testing, as it's called under an umbrella, really became more commonplace during the Vietnam War, when it was used as a preventative tool and also to screen soldiers coming back from war and allowing them to enter into the workplace and specifically enter into the workplace in positions that are safety sensitive. And then in 1989, the Department of Transportation issued drug testing regulations in 6 transportation industries. These include industries such as airlines, locomotive, and commercial driving. So what drove this, in addition to the more commonplace and military, I guess, push to start forensic drug testing, were events such as a fighter jet crash that occurred on the U.S. Nimitz in 1981, in which 14 were killed, and an Amtrak train crash outside of Washington, D.C. in 1987, in which 16 were killed. Other industries with employees in safety-sensitive positions, i.e. healthcare, now test and refer employees with substance use disorder for structured monitoring. With the opioid epidemic and healthcare medication diversion cases, some resulting in bloodborne pathogens outbreaks regularly appearing in the news, the National Council of State Boards of Nursing and the Federation of Physician Health Programs published guidance on the monitoring of healthcare professionals with substance use disorder, and almost all states have structured regulatory monitoring programs in place for healthcare professionals. In addition, with the advent of drug courts and other diversion-type programs, forensic drug testing is becoming more and more ingrained in our society. So what is forensic drug testing? Forensic drug testing, and what does it do? It establishes abstinence. It supports and documents recovery. It monitors the effectiveness of a treatment plan or monitoring plan. It establishes adherence from drug use. It tracks deviations. So for an example, in the case of marijuana or THC, and testing for THC, the windows of detection can be very long, months in some cases due to its fat solubility. So you may want to track THC levels over time to determine whether someone is remaining abstinent, as those levels will decrease over time. And it's also very useful forensic drug testing in legal and criminal investigations. So what's the difference between forensic and medical testing? Well, forensic testing, provides the benefits as described. And medical testing is most typically done to diagnose and treat emergency room patients. It's becoming increasingly used in opioid pain management programs, in psychiatry to confirm medication adherence and therapeutic levels, and to make decisions that affect other aspects of a patient's care. It also prevents dangerous medication interactions. However, realize that sometimes there's an overlap between forensic and medical or clinical drug testing. For example, when a pregnant woman tests positive for an illicit drug, this may not only affect the patient's care, however, may also trigger a mandatory report to legal authorities. So again, it is important to know what you are testing for and why, as even in clinical settings, a forensic testing approach may not only be useful, but legally and ethically necessary. So some of the aspects of forensic drug testing are required chain of custody tracking, required confirmation testing. It's used for the provision of legal scientific evidence. The donor must consent to the test, and it's more expensive than medical drug testing. The one important consideration of forensic drug testing is cost. Forensic tests, because panel size, chain of custody, confirmation testing, the use of observed collections, and medical review officer review can be substantially more costly than clinical testing. Caution should be taken to choose only necessary panels and tailor testing schedules to maximize cost benefits. Also, forensic drug testing frequently uses cutoff levels to lessen the probability of action being taken in response to extraneous exposures. We'll talk more about this in a bit. So first off, choosing a laboratory is very important. Look for a laboratory that has expertise in drug testing and addiction treatment settings or with regulatory standards. The use of a toxicology laboratory is preferred. The Department of Health and Human Services publishes a list of laboratories certified to meet mandatory federal workplace drug testing program standards. And when testing under federal guidelines or federal regulations, those laboratories are required. And in general, CAP, SAMHSA, and CLIA or CMS, Centers for Medicaid and Medicare Services certifications are preferred. Before selecting a laboratory, practitioners should contact the laboratory, and regulatory programs should contact the laboratory and speak directly to the director, toxicologist. You may also want to visit the laboratory. Determine the laboratory's analytic capabilities. Do they test outside of the 9 to 5 that I mentioned earlier? And are they able to tailor panels as appropriate? Do they do confirmation testing, and what is that? What does that entail for that laboratory? Inquire about other panels that test for drugs and drug classes. Confirm that the laboratory follows established federal guidelines and certifications, and determine whether the laboratory's testing procedures are appropriate for forensic use. Ensure that the laboratory provides technical assistance so the practitioner and the regulatory program can obtain help with interpreting test results or determining which panel to order. So commonly used samples or matrices are urine. Urine is by far the most common sample type used. It has been evaluated more thoroughly than the other samples types and is the most common sample type tested. So there's much more experience with urine. Drugs of choice and detection window knowledge is necessary when using urine, but not only urine, but the other matrices also. Hair provides generally a 3-month detection window. And the reason for that is it can detect outside of that 3-month window, but in most cases, the laboratory runs or tests a 3-month sample or growth sample of hair. Blood is generally used to detect recent use, for example, in traffic stops and non-regulatory or workplace drug testing scenarios. However, PET testing, phosphatidylethanol testing, which is a alcohol metabolite, is frequently used to detect alcohol use in 3 to 4 week windows. Nail is similar to hair. Both are keratin. So for the most part, the detection windows are similar. However, nail is a thicker matrix, so is a better base for collector for drugs in most cases. Saliva is a non-invasive, directly observed collection that has reduced risk of adulteration and in some cases is able to detect same-day use. Big negative with saliva, at least at this point, is that it provides reduced detection windows and has a smaller research or experience history. Now, I didn't mention breath. Breath usually is not used as a matrix in regulatory monitoring, but is a point of care testing alternative that can be used. So observed versus unobserved collections. Federal collections require that all collections be directly observed, and it's the preferred method in all regulatory monitoring programs. It prevents substitution, dilution, and adulteration, or it ensures to a great degree that those are prevented, but requires direct observation of the urine stream, not just someone standing in the room with the donor. Unobserved testing can be done, and it may be necessary when the same gender observer is not available. Use of a dry room is necessary in that case. And whether it's observed, the collection is observed or unobserved must be documented on the chain of custody form. So dry room collections require turning the water off on the taps and adding a bluing agent to the toilet tank to avoid sample dilution, not providing hand soap in the restroom where the sample is being collected, not storing cleaning agents in the restroom, for example, ammonia-containing products, bleach, toilet cleaning products, etc., and not allowing coats, purses, or bags into the restroom with the patient. One thing that comes up from time to time is the shy bladder syndrome effect, and when an individual says they cannot provide an observed sample, this is not acceptable and may require the donor to consume liquids over a several-hour period in order to eventually provide that sample. So chain of custody. Chain of custody is the documentation of the trail of custody, control, transfer, and analysis of a drug sample. Both the donor and collector confirm the sample, collection time, collection procedure, and sample seal. Any deviation invalidates the sample. All of this is documented on the chain of custody form. The chain of custody process protects the integrity of the sample and test result and allows for a legal defense. For federal drug testing, the use of the federal drug testing custody and control form is mandatory. In legal cases, all persons handling the sample package may need to be identified across the custody line. In regulatory monitoring or most forensic testing, only collection and receipt at the laboratory may need to be tracked and documented. The window of detection is the range of time that a substance can be detected or a drug can be detected in a sample. It refers both to the time to detection and time to clearance. It's time to be metabolized, eliminated, or excreted. So each matrix or sample type and drug has a different window of detection ranging from minutes to months. So what can affect the window of detection? Chemical properties of the substance, individual metabolism rates and excretion routes, route of drug administration, frequency of use, and amount of the substance ingested, selected cutoff concentrations, the individual's health, diet, weight, gender, etc. So the window of detection, while generally established, it is not set in concrete, and the regulatory program must have additional information, as I just listed, in order to make determinations in regards to a drug test result. So all sample matrices may show the presence of both parent drugs and their metabolites. Drug metabolites usually remain in the body longer than do the parent. Blood and oral fluids are better suited for detecting the drug. Urine is most likely to contain the drug's metabolites. An example is for cocaine. Most commonly, its metabolite benzoyl-ecgonine is tested for. So one must make sure that they're not looking at a cocaine window of detection, but they're looking at the metabolite window of detection. So this slide just gives some examples of detection windows that are most commonly used in regulatory monitoring programs. Alcohol or ethyl alcohol, generally 10 to 12 hours. Now there is another test, a metabolite test, ethyl glucuronide or ETG, that has a window of detection that is 2 to 3 days. So again, make sure you know what you're testing for. Cocaine, I've talked about that already. Amphetamines, usually 1 to 2 days, with chronic use 7 days. Diazepam, 2 to 7 days, but its metabolite nordiazepam is 6 to 24 days. And cannabis THC is usually tested for. It's 1 to 3 days in casual use, but it can be 30 days or longer with chronic use. And again, depending on the individual, if the individual is heavy set, that window of detection may be pushed out longer. It also depends on the cutoff level used. A lower cutoff level more likely will result in the presence of drug or drug metabolite during a longer detection period. And also be aware, again, of the matrix being used or the sample. So for hair and nail, I usually wait up to 10 days if I'm looking for recent use to allow that hair to grow out sufficiently to be able to provide a result that's valid for use, that recent use. One easy way is to use windows of detection. Again, this is a very easy way, but just to have it in the back of your head is the rule of threes. Breath can look back approximately 3 hours, urine 3 days, breath and blood for 3 weeks, and hair and fingernails up to 3 months. And as I said earlier, saliva testing windows range from 1 to 48 hours versus that 3 days or 72 hours for urine. Because most laboratories analyze an amount of hair equivalent to 3 months growth, that's why that 3-month detection window is usually used for hair and also fingernails, which are similar matrices. So cutoff levels determine whether a test is positive or negative. Using the cutoff level prevents a small trace of a drug as resulting in a positive drug test. It takes into consideration possible passive exposures, and lower cutoffs are established for testing populations that have presumed drug use. The cutoff level of a specific drug is the point of measurement at or above which a result is considered positive and below which a result is considered negative. This level is established on the basis of the reliability and accuracy of the test and its ability to detect a drug or metabolite for a period after use. These levels are set high enough to detect concentrations suggesting drug abuse. However, as I said, in regulatory monitoring, since we are not dealing with a general population or a general workplace population, but one that is presumed or identified to have substance use disorder and or misuse, those cutoffs are generally set a little bit lower. Confirmatory testing is required for all regulatory and forensic testing. Usually a presumptive test, a point of care immunoassay type test is originally done to detect the presumption of a drug or its metabolites in the substance. And then the use of a high sensitivity and specificity testing is then done to confirm the presence and quantity of specific drugs and their metabolites. Gas or liquid chromatography combined with mass spectrometry is preferred. And then certifying scientists confirm each positive. In addition, validity testing is done for all positive samples and in many cases negative samples. And validity testing tests creatinine levels, specific gravity, pH, also temperature, maybe the presence of oxidating agents such as bleach to confirm that, yes, indeed, this is a valid human sample. Samples are considered dilute or invalid when urine creatinine is below 20 milligrams per deciliter and a specific gravity less than 1.003. So in forensic testing, split samples are required. And I say required as mostly applied to urine samples. In some cases, I'm aware of laboratories that do not require split samples of blood, let's say. Split samples are a benefit to the donor as the A sample is generally used for testing, and then the B or the split sample is then held for positive tests, generally up to 1 year. And that split sample then can be used at request of the donor or in some cases legal authorities to determine whether or not, or determine the strength of that original positive or negative sample. It provides the option for an independent reevaluation of the result. And in most cases, it is a truly independent evaluation because the split sample or that B sample is sent to a second objective laboratory for analysis. Testing schedules are important. Random testing is preferred. Day limitations may be necessary due to collection site access. So a true random schedule would include, 7 days a week testing, but in many cases it's limited to 5 Monday through Friday because of collection site access. So frequency should be determined by individual circumstances, i.e. the ability to pay, safety-sensitive work, and patient acuity. Consider test detection abilities and windows of detection as discussed, and testing frequency may be decreased over time and in line with recovery stage. The medical review officer is a very important part of the regulatory monitoring and or forensic drug testing team. Simply put and explained by the U.S. Department of Transportation, a medical review officer is a person who is a licensed physician and who is responsible for receiving and reviewing laboratory results generated by an employer's drug testing program, evaluating medical explanations for certain drug test results. The medical review officer has been termed as the gatekeeper or advocate for the accuracy and integrity of the drug testing process. Medical review officers provide quality assurance review for the drug testing process, determine if there's a legitimate medical explanation for laboratory confirmed drug test results. The MRO reviews laboratory processes, chain of custody documentation, interviews the donor, collects collateral, i.e. donor medications, and among other processes to determine the validity and strength of a test result. The medical review officer recommends follow-up actions to include additional testing and or collection site training. The medical review officer is an essentially important element of any forensic and regulatory monitoring drug testing program, as the medical review officer provides objective, legally defensible program oversight. The medical review officer's opinion will anchor legal decisions, which will be represented in court as expert testimony. So it is important to take away that a positive drug test is not sufficient evidence for a diagnosis of a substance use disorder or noncompliance with a regulatory monitoring contract or agreement. It does not explain whether a patient's symptoms or donor symptoms are caused by the presence of a substance. In most cases, a drug test does not measure impairment, and in most cases, a drug test does not measure patterns of use over time. So be very cautious when interpreting a drug test. Use your laboratory resources, use your certifying scientist resources, use your medical review officer to make a final determination as how to act on a drug test result. So regulatory monitoring and recovery, to wrap up, the purpose of regulatory legal monitoring is to use practical evidence-based structures for the evaluation, treatment, and management of individuals with substance use disorder. Public protection is at the core of any monitoring program, and it is in the best interest of the program and stakeholders to have a strong, legally defensible drug testing process. While this presentation focused on forensic drug testing, as stated by the National Council of State Boards of Nursing, evidence shows that approaching addictions as a treatable illness is highly effective financially and has broader positive societal impacts. When scientific tools are tailored to meet individual needs and individuals are appropriately monitored, the public can be assured they are being provided appropriate and safe services. So thank you very much for your attention and time. There's my contact information. Feel free to contact me at any time if you have questions about this presentation. And here is a list of the primary resources used for this presentation. Thank you very much.